Well, thank you. It's really a privilege to be re-invited again. I want to thank everyone for being here, and I want to thank Dan for inviting me. It's a real privilege, and thank you. As you know, Dan is very persuasive. He didn't have to persuade me to come to this, but as soon as I let my guard down, I was so thankful to be here. I let my guard down last night, and Dan reminded me kind of gently, as Dan does, that we, that's a singular form of the word, should be writing this grant. Dan doesn't twist arms, as you know, but the x-ray was negative. It was okay. I really do want to thank you, and I want to thank Dan for reminding me both of my duty and the privilege of being here. Now, what I'm going to do in the next 20 minutes is to talk about original research, a project that I've been involved with really almost my whole career, and that's how to understand sudden death. What is sudden death? As we've heard this part of the country is probably the nicest part. I'm not leaving, okay? My kids are all Southerners now, and this is the greatest part of the country, but it's also, as everyone has pointed out, we have a lot of health problems here, and one of them is sudden death. So I'm going to talk about that. Everything I'm showing is really original data from us. It's all been presented as abstract forms. Some has been published. So now, I'll just tell you why I got thrown. This will tell you why I got thrown out of the EP lab. I hit the buttons wrong. So I don't have any conflicts for this presentation. And this is the outline. Basically, there's a lot of causes for sudden death and a lot of names for it. If you study sudden arrhythmic death, you're studying a very small number of people. If you study sudden coronary death, you study a little larger number of people. But if you just look at everybody who dies suddenly and unexpectedly, you're studying a lot of people. There's always been this paradox. Sudden death is rare. It's a very rare event. And yet the paradox is most families, I would say most, at least a quarter to a half of families, have a family member who died at a young age for no reason that could be explained. And this is the paradox that we try to investigate. And so I'm going to outline the role of hypertension and left ventricular hypertrophy. As my own personal view is this is the cause of most sudden deaths that we see. It's not coronary disease. I'll show you some data on that. I'm going to show you some preliminary findings in Wake County. Wake County is a very diverse county, population diverse, and it's still a southern county. And I'll talk of some of our early prevention efforts. This is our research team. This was a photo taken almost 2 years ago. But these are, as you notice, they're almost all students. We ran this project really with, actually I shouldn't say the student labor, but the payback for the students was that they all ended up in med school or in a good residency program. So it's a real debt. The work I'm really showing is work done by really, really dedicated young people. Now this is an example of sudden death. This was a woman I cared for. She survived because she came into the hospital and fibrillated multiple times in front. This is someone with long QT syndrome. Now, and that's a part of sudden death, but it's not the whole part. This is a concert diagram just showing you how we decided to study sudden death. We took the assumption that we know nothing about the topic, and so we worked with emergency medical services in Wake County, and basically we identified everybody who was dead in the field. They didn't get transported to the hospital, they were just dead. And from that, we culled out exclusions. And then we had the cases adjudicated by a panel of 3 cardiologists. And so what we ended up was about, in a year, Wake County has a population of a little over 1 million people. We identified per year 200 cases, so 400 cases over 2 years of all-cause sudden death. Now, pardon the joke slide, but it says, my approach is non-traditional, but from a uniquely Western perspective. Again, the idea here is, assume we know nothing about this topic, let's go in and find out what we really can learn. And what we learned was, to be blunt, was shocking. First off, 14% of all deaths under age 65 are due to sudden unexpected death. This is really a high percentage of all deaths. This includes of all deaths, including trauma deaths, 14% of all deaths under age 65 are where somebody just is found dead in bed next morning, they're found on their kitchen floor, they're found someplace. The other thing we found is that 2/3 of the, if you study sudden death without taking this approach, you exclude 2/3 of all deaths. So you're studying only a select group of people if you don't take a population-based approach. And no surprising, hypertension turned out to be the leading associate of sudden death. Over 70, I'll show you data, 70% of our victims had hypertension, and I'll show you data that they weren't treated. Coming back to Michael's point, they weren't treated. It wasn't about whether they were treated with good drugs or bad drugs, they weren't treated. Coronary disease was prevalent, but was only prevalent in about 25% of victims, 15 to 25%, depending how they were assessed. And the other point we found, which was valuable, is that death certificate data was wrong. Only half of these victims were identified anywhere in the death certificate as a sudden death. Now, the other thing that came out, and this is in review right now, this paper, basically is that if you look at years of life lost, what you can see on this slide, the yellow is coronary deaths, and then right below it, the dotted line is the sudden death. So sudden death accounts for a major portion of years of life lost because it's occurring in young people and it's occurring with a relatively high frequency, high incidence. Now, this slide is important because it was one of our first prevention efforts, and the message on this slide is don't wait for the ride. Okay, this is showing you that if we're counting on EMS services to save you when you drop dead or your husband or wife drops dead, you're wasting your efforts. Don't wait for the ride. This just shows that resuscitation couldn't even be attempted, and Wake County EMS is probably one of the best in the country. They're top-notch people, great services, but they couldn't even attempt CPR in 60% of the victims. And the success rate here obviously was 0, because we only studied people who actually died. But if you have a resuscitation in the field, if you die in the field, even if you do it right outside the emergency room, the EMS is there in minutes, the chances of leaving the hospital is probably about 15%. So sudden death has to be prevented. Now, this didn't show up well, but we also looked at the relationship. Should be a map of Wake County, and this is a relationship of the nearest external defibrillator to where the people died. People died at home, okay? They didn't die in the airports. So the defibrillators, there was no use of an external defibrillator in any of the victims, of the 400 victims we saw. And the reason was they were too far away. They weren't accessible. Don't count on the airport defibrillator to save your life if your family member has sudden death. I'm sorry, this is a better map of Wake County. This just shows Wake County, and they're attempting to show the relationship of where people were dying suddenly and where the defibrillators were located. That was presented at the American Heart Association. Now, what causes sudden death? Now, this is just a cohort study. We're just looking at associations, but that's a great way to understand a path to prevention and what you should do. And Mike, I think as you kind of predicted, you would predict the biggest associate or odds ratio for sudden death was hypertension. Now, this is for men and women. We had a control group. The control group were people at the UNC Health System who were alive and sought health at the UNC Health System. So we could actually calculate odds ratio. So if you had hypertension, your odds of having sudden death increased, it was 3 to 4 times higher. Coronary disease, oh, wait a minute. Coronary disease was present, but again, the incidence was low and was not the dominant risk factor. So now to talk a little bit about hypertension, this is not our research, this is research that, I'm trying to remember who the lead author on it, but basically it was really looking at the relationship of blood pressure to sudden death. And there's no question that a rise in blood pressure is associated with sudden death. Unfortunately, with randomized trials, and this was a Cochrane review, they could not show a relationship between a reduction in sudden death and a reduction in blood pressure. Now, there are problems with this, not that I'll get into in a minute, But the good thing was that the life trial and some of the other trials showed, or the life trial is the one I remember vividly, is that if LVH is actually reduced, then sudden death is reduced. And this is really important because this is starting to touch on a mechanism for sudden death and a preventable mechanism, a treatable mechanism for sudden death. I'm going to skip a couple slides, just don't show too well. Now this is sorry, the last slide didn't show up well, but just to describe what it showed, we found in our victims about a 50% prevalence of left ventricular hypertrophy as assessed by autopsy or by echocardiogram or occasionally by ECG. So we had all medical records on these victims, and we could delve into what's the probability that LVH was individually associated. Now, a lot of people never had echoes or ECGs, so that's a attributed value. But our estimate right now is at least 50% of victims of sudden death have clinically measurable left ventricular hypertrophy. Now, slide is touching on some of the themes that Dr. Moore talked about. We always think of sudden death as somebody who doesn't see the doctor, just doesn't take care of themselves and just dies. Well, that's not true. This is we went back and looked at who saw the doctor before they died. And what we found is about a third of the victims saw the doctor a lot. If you look at this top graph, this is about a third of the victims, and in the 2 years prior to their death, they saw the doctor with increasing frequency. Now, there's another group in the middle, that's kind of about the average for the US of seeing the doctor, and then the group at the bottom, which was another third, didn't see the doctor at all. So what I'm pointing out here is that 2/3 of sudden death victims are seeing the health care, are seeking out health care, are seeing the doctor. Oh, okay, so why did they die? Well, we had the chart, so we could see what medicines were at least on the medicine list. Now, this is we recognize that it's not a perfect measure, but basically, well, look at this. People with hypertension, only, what am I seeing there? Like a third on blood pressure medicines that save lives. 75%, 70% of the victims have hypertension? And I can't read that, Mike. Does that look like they're only about 20% are on ACE inhibitors? ACE inhibitors are good for preventing LVH, right? They're kind of important medicines. Yeah, so basically, even for coronary, there's low use of aspirin, low use of evidence-based medicines in people who are at clearly high risk of medical problems. So we went back and looked at substance abuse, and Dr. Moore, as he has in the past, nailed it. There was a large amount of mental illness. Over 60% of the victims had a diagnosed mental illness. Now, the mental illness might have been anxiety, depression, but it was a high percentage of people had mental illness. And substance abuse, alcohol abuse was also high. We didn't get a high rate of opioid use, but we have some other data from another project that we can talk about that showed that opioid use was a strong predictor of sudden death. Now, this is not our work. This is a slide I borrowed from Dr. Cassio at the Environmental Protection Agency. We went back and looked, well, what's going on here? What are other environmental factors for sudden death? Do you think it's important that we breathe clean air? Do you think it's important that, that we're not breathing in diesel dust? Well, it turns out that the epidemiology shows that, at least for a heart attack, right here, you get about a 15% increase in risk of sudden death depending on the particulate matter of diesel dust, a small particle in the air. So we went back and looked at our work, and we looked at the day of death with a 2-day lag period, because that's what it takes to juice up the inflammatory markers, and days when the people didn't die. And what did we find? We found that there was a 15% increase in the risk of sudden death associated with bad air days. Now, that's published, so air quality makes a difference. Well, I don't want to be political here. I won't be political, but I can guarantee you we ain't going to be changing regulation for air quality in the next few years. So what are we going to do? Well, let's look at parks. Let's look at tree cover. Because tree cover is part of economic development. Park greenways are important for cities. So then we looked at whether tree cover mitigated this harmful effect of air quality. And it did. That's in review at the American Journal of Cardiology right now. If any of your reviewers, remember it's good paper. Sorry, I've got a lobby these days. The point here is that we actually saw, and that was adjusted for poverty. So we showed that poverty was associated with this relationship between sudden death and air quality, and then we showed that that difference could be removed or blunted by looking at the location of where people died and what the tree cover was in their area. Now, what about rural counties? Now, the South is really, we're a rural part of the country. And we also, because we had location and we had some ideas, we looked at rural counties have a higher incidence of sudden death than urban counties, higher incidence rate. And the higher incidence is best predicted by lower mean household income. That's true. Also by poverty. And that healthcare access didn't make a difference. There was no relationship between healthcare access, disease prevalence in the county, but poverty and opioid use were the predictors that were associated with this gradient between rural and urban counties. I'm here to fix the lasagna. I show this slide because, we're all scientists, but we're also doctors, and we've got to do something about this. This isn't something we just learn about. So what are we going to do? Well, we've done 2 pilot studies, and they're really not even pilot studies. They're pre-pilot. They're even, I don't even want to call them feasibility. It's really to judge interest in the community and whether there's a way of addressing sudden death. Sudden death is devastating to families. So we worked with a group in Surry County in North Carolina, and we really worked with the Heart Association. Dan gave us some good direction to some of the programs in the Heart Association. The idea here was whether we could put together a consortium that would address sudden death using community health workers. Now, so there's real interest. We learned from this real interest. There's the potential to do something, but we stopped the project because we didn't feel we could had enough traction to actually show a reduction in sudden death. We thought that these were too many social problems going on, that if we didn't deal with the social issues, we wouldn't get a benefit. We'd lower blood pressure a little bit, we'd do something with diabetes, but we just didn't feel we'd had enough. We didn't feel we were aiming at the right target. You never buy me anything I want. I show this because that was what we came to. We think we're going to buy a research project that's important for, lowering blood pressure, better control of diabetes, better improving access to care. But it just didn't feel like we were going after the right intervention. So what we're exploring now is social prescribing. This is based on work in the UK where they have really felt that they can get a return on investment. And by the way, that's the new buzzword nowadays. You gotta save money or make money. Okay, sorry, I'm being political again. But that's not wrong. And so in the UK, they're using social prescribing really to help engage people with the community and also with the healthcare system. And this was a review one of our students did based on the Rotherham project that's in the UK. And they're basically, they found a return on investment of about 50 cents on the dollar, with the most return after the program was in effect. So what this program is really social prescribing. It's a program of really promoting engagement using volunteers as well as paid individuals. Now, this hasn't been subject to the rigorous evaluations that we all demand on our data, but it certainly is being picked up by other places in the UK as a way of dealing with the root causes of health problems. And we think it would apply to such a broad-based disease syndrome like sudden death. So my conclusions: sudden death is common, but is under-recognized in the southern population. Victims appear to take to have inefficient care. It's not like they're not seeing the doctor. They are seeing the doctor, but the care seems to be mismatched with what the patient needs, and have a high prevalence of inefficiently treated chronic disease, particularly hypertension, LVH, and diabetes. Most victims are not candidates for resuscitation. You can't wait for the ride. The population and clinical prevention programs have the potential to reduce the incidence of sudden death in the Southern population. It's real. We think we can do it. So this is my apology slide. The caption just says, no one is making you do anything you don't want. I'm not saying, I'm just saying we're all headed to Dodge City and we think you should come along. Now, it's an apology slide because that's really what I'm saying. I'm saying we, as physicians and leaders, need to move people to a place that at least they don't seem to want to go. And it's going to be a challenge. But I think efforts with social prescribing, efforts with disease management, and community efforts have the potential to do that. Thank you very much for inviting me.